Hi everyone, it's Emily Bach. I'm a women's health nurse practitioner student at Regis College, and today I'll be presenting on adenomyosis. Adenomyosis is a uterine disorder where the endometrial tissue, which includes the glands and stroma of the endometrium, invade the muscular layer of the uterus, which is the myometrium. This disease is similar to endometriosis because the endometrium is displaced. Except with endometriosis, it's outside the uterus. Adenomyosis is in the uterus. So this abnormal endometrium that forms into the myometrium follows the same hormonal changes that the normal endometrium would follow. So it responds to hormone levels and proliferates and then bleeds. So it leads to hypertrophy of the myometrium. And there's two forms, including diffuse and focal adenomyosis. Diffuse adenomyosis is throughout the entire uterus, resulting in an enlarged and boggy uterus. Upon dissection of the uterus, it reveals a thickened myometrium, and there's areas of hemorrhage that represent the endometrial bleeding within the myometrium. And then focal adenomyosis is a localized area of glandular tissue within the myometrium and is oftentimes confused as a fibroid. You can see up here in the picture, there's a focal adenomyosis, so it's just a little tiny piece, and then there's an adenomyoma, which is a larger cyst-like structure, and then there's diffuse, which is throughout the entire uterus. And then this bottom left picture shows a uterus with adenomyosis, so it's significantly enlarged, and then on the right is a normal-sized uterus. Epidemiology. It's unclear exactly how many women truly have adenomyosis because of underreporting and underdiagnosis. Studies estimate between 5 to 70% of all women have adenomyosis, but more recent studies suggest that that number is actually 20 to 35% of all women. Adenomyosis can only be diagnosed after a hysterectomy when the uterus is analyzed and the histology report is able to be viewed. So after a hysterectomy, when a uterus is sent to pathology, it's seen that 14 to 66% of all uteruses have adenomyosis. Previously, it was believed that only women in their 30s to 40s or 40s to 50s prior to menopause and women who had had numerous pregnancies and children could be diagnosed with adenomyosis, but we've seen that that's just who's presenting for a hysterectomy and getting formally diagnosed with adenomyosis, and that teenagers and younger women and women who have never been pregnant can also still have adenomyosis. There are several risk factors for adenomyosis. One major risk factor is increased estrogen exposure, and then the other major risk factor is prior uterine surgery. So increased estrogen exposure from increased parity, early menarche, short menstrual cycles, being overweight or obese, oral contraceptive pills, or tamoxifen. Prior uterine surgeries can include a D&C, a C-section, or a myomectomy. Other risk factors include being middle-aged, history of spontaneous abortions, having other uterine disorders like endometriosis, endometrial polyps, or fibroids, and it's estimated that up to 90% of patients with endometriosis also have adenomyosis, and then a family history of endometriosis is also a risk factor for adenomyosis. Subjective findings. The two most common symptoms associated with adenomyosis include heavy menstrual bleeding, menorrhagia, and dysmenorrhea. A lot of symptoms of adenomyosis correlate with endometriosis. They have very similar symptoms. Other symptoms include chronic pelvic pain, infertility, pain with sex, prolonged menstrual bleeding, pelvic pressure, urinary frequency. They may endorse a history of having several pregnancies or prior uterine surgery. And it's also important to note that up to 30%, 1/3 of all women with adenomyosis may have no symptoms at all. Objective findings. On physical exam, the provider may feel that the uterus is enlarged and symmetrical as opposed to like with a fibroid where it feels asymmetrical. The uterus is often boggy or soft, tender on exam. The uterus is mobile, it's not fixed. That's one difference between adenomyosis and endometriosis. Oftentimes, with endometriosis, due to the adhesions and depending where the endometriosis is, the uterus can become fixed. That's not the case with adenomyosis. Fibroids can get quite large as opposed to adenomyosis, where the uterus is enlarged, but it's not as enlarged. It rarely gets past 12 weeks gestation, the size of 12 weeks gestation. Or the patient may have a totally normal bimanual exam with a normal uterus. Differential diagnoses. So some other possible diagnoses based on the patient's symptoms could include endometriosis, fibroids, uterine cancer, or really any of the palm coin that causes abnormal uterine bleeding. The workup for adenomyosis. So whenever a woman of reproductive age presents with abnormal uterine bleeding, an enlarged uterus, or pelvic pain, a pregnancy test should be done to rule out pregnancy as a cause of their symptoms. A hemoglobin and hematocrit should be obtained if the patient's having heavy menstrual bleeding to rule out anemia. The first-line imaging for pelvic pain or an enlarged uterus and or abnormal uterine bleeding is a transvaginal ultrasound. Rarely is an MRI required to determine the difference between a fibroid and adenomyosis, but that's really the only time it should be used. MRIs can also diagnose adenomyosis, but they tend to be more expensive than ultrasounds, and the accuracy between the two are pretty much the same, which is why the transvaginal ultrasound is preferred over an MRI. If the patient's having abnormal uterine bleeding and their transvaginal ultrasound is concerning for endometrial hyperplasia, then an endometrial biopsy is recommended to rule out endometrial cancer. But really, the only definitive way to diagnose adenomyosis is after a hysterectomy on the pathology report showing the histology of the uterus. Findings suggestive of adenomyosis include endometrial infiltration, so there's myometrial cysts, or there's linear striations radiating out from the endometrium. There can be smooth muscle proliferation, which shows up as either focal or diffuse asymmetric thickening of the myometrium, typically with the posterior myometrium being thicker. There's loss of a clear border between the endometrium and the myometrium, and there's increased myometrium heterogeneity. There's also thickening or disruption of the junctional zone, and on color Doppler, there shows the uterus is found to have increased like tortuous vessels throughout the myometrium, suggesting it's like highly vascular. For the plan of care, typically first-line therapy includes pharmacological interventions. NSAIDs are used to inhibit prostaglandin synthesis and decrease associated dysmenorrhea. Hormonal suppression therapies are used to decrease estrogen levels and reduce endometrial proliferation. This includes oral contraceptive pills, progesterone IUDs like the Mirena, Depo-Provera, Danzazole, GnRH analogs, or antagonists like Orilissa or Lupron injections, as well as aromatase inhibitors. If symptoms are severe, worsening, or limiting the woman's quality of life, then surgical interventions may be necessary. There are several surgical procedures that can help with adenomyosis. The first one is uterine artery embolization, which reduces the total blood flow to the uterus, resulting in necrosis and reduces the size of the uterus, which helps improve symptoms. There's also high-intensity focused ultrasound surgery, which uses ultrasound beams to cause thermal ablation and necrosis of the adenomyosis, leading to a decreased uterine size and symptom improvement. There's surgical adenomyectomy, which is radical excision of the adenomyotic tissue. There's also an endometrial ablation that can be done by a hysteroscopy approach. to reduce menorrhagia and dysmenorrhea in women who are done with childbearing. It tends to be less invasive than a hysterectomy and helps reduce the blood flow and associated symptoms. And then a hysterectomy is the only definitive cure for adenomyosis. Non-pharmacological interventions that also fall under the categories of health maintenance and health promotion include preventing being overweight or preventing obesity, as well as weight loss to manage obesity. What we've found is that being overweight and being obese results in estrogen excess, which can then worsen the adenomyosis symptoms. So by eating a healthy diet and exercising can help prevent adenomyosis or help manage symptoms and reduce symptoms. It's important to educate the patient on adenomyosis, what it is, the signs and symptoms of adenomyosis, what diagnostic tests are used, available treatment options including their side effects, risks and benefits, and the impact on fertility. It's also important to address the patient's psychosocial needs. This includes discussing their quality of life and the impact their disease has on their quality of life. It's important to evaluate the patient for signs and symptoms of depression because depression is more common in women with adenomyosis, and the need for antidepressant therapy is more common as well. It's also important to inform and reassure the patient that the severity of their symptoms determines their therapy or treatment. Referrals. So if a patient is having worsening symptoms, they should be referred to a gynecologist for possible surgical intervention. If they are pursuing a uterine artery embolization, then it would be appropriate to refer them to interventional radiology. And then also if they have any concerns regarding their fertility, then it would be appropriate to refer them to a reproductive endocrinologist. Follow-up. So patients on medical therapy should follow up every 3 to 6 months. If symptoms worsen, then surgical interventions may be necessary and they should follow up sooner, or they should follow up sooner if their symptoms are worsening at all. Long-term management of adenomyosis typically isn't necessary, especially if symptoms are well controlled. Future management is always determined by the patient's symptoms, so if their symptoms really aren't bothersome, then they don't necessarily need any treatment. And it's important to talk to the patient about avoiding trauma to the uterus and avoiding estrogen excess to prevent worsening of their symptoms. Here are my references I used. Thank you so much for watching my presentation, and I hope you enjoyed it.